لن تخرق الأرض ولن تبلغ الجبال طولا ذلك كان سيئه عند ربك مكروها صدق الله العظيم.
Thank you, Dr. Ali. I'm opening the floor to our panelists right now. If they have anything to say, if they want to say a few words before we get on to our addresses and sponsor videos, then kindly this is the time. Dr. Rutledge, would you like to say something to our panelists or our attendees?
You don't know me very well because I'm always talking. So it is an honor and a pleasure to see my friends from Pakistan again, Dr. Mumtaz and the others who are visiting. And hello also, I hope you will be as gentle and friendly to Dr. Ilan, my new friend and partner here in San Diego, California, and in Tijuana, Mexico. And I remember very fondly when the world was a place where we could travel and be with one another. I have so much respect for Dr. Aatif and his team, and the opportunity to work with my brothers and sisters in Pakistan. I honor you. It's my pleasure to be here tonight, and I hope that I will not talk too much. Thank you.
Sir, thank you so much. We are counting on you talking so much, sir. You are
well, I don't think you'll be disappointed.
So this is not the time to start muting yourself, sir. So,
no, sir.
Thank you.
Fear not.
Dr. Jaleel, would you like to add something to what Dr. Rutledge is saying?
Yes, thank you very much. It's a pleasure being here. I'm blessed and very lucky to be working with Dr. Rutledge for the last year, and hopefully to learn something with your colleagues there. So thank you for the invitation.
Okay, thank you, Dr. Jaleel. Yes, sir, Dr. Rizwan.
Yeah. Thank you. I apologize for interrupting. Actually, I was on connected and I suddenly got interrupted when the call came. I'm really truly grateful for all your effort and your interest and your time for this very important area. And a lot of obesity is a very pandemic over here. And again, in these circumstances, you're taking time out and explaining everything to us. And you will find our audience very receptive and open to discussion with you. And we look forward to your future support and advice and direction for developing this service in our tertiary care unit. And I'm grateful to Dr. Aatif Shami, who has taken the lead in Islamabad, the capital city, in this particular field. And I wish him and you all the best. Thank you very much.
Thank you so much, sir. It's a great honor having the dean as well, such a supportive dean who allows us to have all these conferences, who allows us these resources, and who actually supports us in all our activities. Thank you so much, Dr. Rizwan Taj. It's a pleasure to have you here. Dr. Mumtaz, would you like to take the floor and say something to all our panelists and attendees?
Thank you very much. It's nice to see you in person, bright and happy as always. You know, we actually owe a lot of gratitude to you. Your first visit to Islamabad, organized by Aatif, was actually a milestone in the further bariatric surgery. Actually, it was, because it used and we got to know about the MGB, and the courses that you've held have actually elaborated and explained the whole thing. The world was against it, but now it seems that has gained popularity all over the world. We owe you this, and we are fortunate that you're here today with us. I'd also like to thank the panelists who are actually from Europe and the UK to be up at this time tonight. And with what Aatif has organized, with all the problems he went through with the internet, I'd like to congratulate him for the team that he has raised and the event that he's organized. And MGB has been popularized by you and Aatif in Pakistan, actually. We are a small society and a young society, and the pandemic did hit us hard in that we could not have face-to-face training sessions. But the Zoom platform kind of fills in the gap, and we get to see each other and watch each other work. This workshop, I'm sure, will further the cause of bariatric surgery and the MGB. Thank you very much for being here. Thanks to all the panelists for contributing their time.
Thank you, Dr. Mumtaz. Dr. Ghulam Siddiq, would you like to say a few words as well?
Well, good morning and also good evening to those who are in the West. I, on behalf of PSMBS Rawalpindi Islamabad chapter, is really delighted, and I'm grateful that Aatif did such a wonderful job. He's not only a good surgeon, but he has proved to be a good organizer as well. And as Dr. Mumtaz mentioned, I think Dr. Rutledge, he is obviously the pioneer of MGB, but popularizing it in Pakistan, I think Aatif Inam is the person who played a vital role in popularizing it here. In the form of lectures, in the form of workshops, and on every forum. And that's the reason I think people would change the MGB to OAGB or whatever, but it is Dr. Rutledge. It's an asset that you have, and we all appreciate your work, and you are going around the world and still clearing the minds of those, the doubts in the minds of those who are opposing it, and now everybody is coming into MGB and OAGB. And in the end, I'm really grateful to all those panelists. I wish we had an in-person meeting, but unfortunately due to COVID, but still I'm grateful to everybody who is on board. And thank you so much, Dr. Aatif. Thank you.
Thank you, Sir Ghulam Siddiq. Dr. Rutledge, everybody seems to be a fan of yours. So it's a great honor.
Only on this meeting.
Sir, I guess those are the ones that count. And hopefully we're just ready in the OR. We're just getting our anesthesia team is scrubbing up. The patient is.
Should I do
ready.
a little talk while we're waiting for the team to start?
Of course, sir.
Okay. So for the group, I have several topics that I have found interesting that you can choose from. So I will mention a few, and maybe Dr. Mumtaz, you can guide me of which you would like to hear. So I will mention a few topics that we can use to fill the time until the operating room team is ready. One is the question of reflux. And so although the MGB has spread through the world, there has been this kind of abiding paradox, so that we have good honorable surgeons reporting that they see very high incidence of bile reflux, and good honorable surgeons saying, in fact, it is such a problem that in fact, in this year, earlier this year, Australia reported a series of several hundred of their MGBs, and they reported as part of the study that 10%, 1 out of every 10 of their MGBs had to be reoperated on for reflux so severe that it could not be controlled. On the other hand, we have maybe tens, maybe now hundreds of thousands of MGBs reported by other surgeons, and they are seeing quite low incidence of reflux. So I am honored to be part of a paper that was spearheaded by a surgeon from Iran, and he did a evaluation of a dozen more studies and showed that the incidence of bile reflux reported was very low. And so I have this in my mind as a paradox, where you often will hear surgeons argue with one another, sometimes without much data, but with lots of emotion. And so one of the paradoxes I think we could talk about for a few moments is the issue of bile reflux and the MGB. And I have a few tips and technical topics that you might be interested in. If you wish, I can talk about that topic for a minute.
Yes, sir, that is great. Could you please outline those topics? And sir, thank you, Dr. Chetan, for joining us. Can you just test your mic? And we'll just give the floor back to Dr. Rutledge.
Hello, good morning. Very good morning from London. Hello, Dr. Rutledge. Good to see you. Good to see you, Dr. Aatif, and the whole team there. Sorry, I'm 10 minutes late. It's 4 o'clock in the morning here. I normally sleep at 2 o'clock, so it's a bit tricky to wake up at 3:30.
Sir, thank you for joining us. We know that the time difference is a huge burden on your physical self, but thank you for making this effort and powering through with us. Dr. Rutledge, can you please continue? Yes, with the technical points of reducing bile reflux.
Good. So I'm going to talk briefly about reflux. And so I'm just going to go ahead and set up my screen. I'll be 1 second. Okay, so why it happens with the MGB and how to resolve it. So I'm going to talk a little bit about that. Don't hesitate to interrupt, and I can stop the discussion at any time. So I jokingly have done this in the past, and I said, "Come with me if you want to live," from Arnold in the Terminator. So that's a little joke. So today's presentation, MGB causes and treatment, and surgical techniques, errors, or lifestyle and prevention and treatment ideas. I give thanks to my friends from India who had to put up with me in their house for a year during the pandemic. And of course, I'm excited to be working now in San Diego with Dr. Ilan. It's about 25 years ago, since September 1997, when I did the first MGB. And now you're welcome to join us on all over the internet to talk to some of my patients who are 10, 15, and 20 years after their MGB. So reflux in patients without surgery, with the sleeve, the MGB, and other operations, I'd like to talk about understanding it, the causes, prevention, and treatment for better outcomes. And again, don't hesitate to interrupt at any time. But if you wish, I can go over some of the causes and treatment, not just for MGB, but possibly for sleeve and Roux-en-Y, and for non-operative patients as well. So this is the MGB, and the MGB is nothing special. It's just an old operation that I used to do 40 years ago for peptic ulcer disease. And some of you here, I see a few gray hairs or a few missing hairs, suggesting you might have been old enough to remember these operations before Prilosec and the other medicines. And so I say there's a paradox, that there's excellent results reported by myself and others with the MGB using my original technique, yet there are other reports of poor weight loss, excessive weight loss, bile reflux, even leaks and death with the MGB. And these two things don't seem to match. So I'd like to comment on them if you're interested. So I begin, though, to mention that there is a reflux epidemic all throughout the world, not just in MGB patients. So I'll give you just a reminder of a few pieces of background. GE reflux, one of the most common disorders in the United States and Europe. 9 million visits annually in the United States, the most common discharge diagnosis for GI disease. And esophageal cancer, strongly related to reflux, has increased sixfold from 4 to 23 per 100,000 patients in the past few years in the United States. There are some studies that in patients who eat like Americans, 1 out of every 5 people have reflux. They don't have an MGB. You can't blame a quarter or a fifth of the population of the United States having reflux on my patients. Here's some data from 1990 through 10 years ago, and look at the rise in reflux up to over a quarter in the United States. Reflux is rising, and reminder, it's not just the MGB. So I'm going to present a brief hypothesis that reflux could be related to the patient's diet and advice from the surgeon, but also maybe it's the surgery and the surgeon at the time of surgery. So I'm going to give a hypothesis that if you see a patient after your surgery and they have reflux, there are 3 possible explanations. One is it's the surgical procedure itself, and we'll talk about that. The second is the surgical procedure might be good, but there could be technical errors. And we'll talk a little bit about that because there's something we could just fix. And then I don't think you'll be that interested, but I'm very interested in this now. And the post-op patient diet and lifestyle is very important for appropriate management after the MGB. And I hope you'll ask me some questions about that. So let's give one example. The surgical procedure could definitely be the cause of GERD. And a lot of surgeons say, well, look, you have reflux after the MGB because the surgery itself is flawed. Now, what I would say, though, is there was clear evidence of a flawed Billroth 2 type loop gastrojejunostomy by the old Mason loop. That within a year or 2 after it was performed, because the gastrojejunostomy was close to the EG junction, that was abandoned after several thousand patients had performed. So I would say in this case, the surgical procedure itself is inherently flawed. And that's one reason why you might get bioreflux. On the other hand, the MGB using what I call the original technique tends to resolve GERD. In my series, I think Chetan has published some studies on this as well. And other surgeons I've talked to show low incidence of bioreflux after the MGB. So in a study with Dr. Kular, we looked at 131 patients, 131 surgeons, and they reported on 36,000 cases of their experience. 23% of patients before the surgery reported GERD, and post-op it was down to 8%. So in this case, this is an example. It's my data, my study, so maybe I'm biased, but here it looks like the MGB is working well. But in some surgeons' hands, the MGB actually causes GERD, and this is the Australian study I was talking about. So here they said 11% of patients had to be reoperated on for Roux-en-Y gastric bypass, so 1 out of 10. And not just reflux, but so severe it required revision surgery to treat reflux. So this, I wonder, and my hypothesis today that I'll talk about is this
The technical error of the surgeon, yes, we know those very good.
No, you do not. Okay, so imagine that there is this paradox. Some surgeons seeing high rates of complications of reflux in particular, but also marginal ulcer and perforation, and other surgeons reporting low rates. So what I think Dr. Aatif has in mind for today is to help us identify issues where we could improve our skills and have better outcomes. So for example, to our brothers in Australia, possibly there are some things they could change in the technical performance of their MGB. And I'll mention some obvious mistakes that I think your team is aware of, but just for example, the short pouch. When you make a short pouch, you could essentially recreate the Mason loop, and we already know that that's not a good choice. So that's likely, and we already know this, that is going to cause a persistent, severe bioreflux. The other things that I have seen, and I have some videos and some slides you may find interesting, is you can twist the pouch. I did a presentation in Turkey several years ago, and I was doing my technique, and several very experienced surgeons got up and said, no, you shouldn't do it that way. And then I came back and showed later that the way they were doing it was actually twisting the pouch almost 180 degrees. And I have a few slides we can look at that. The anterior gastrojejunostomy will lead to a twist. Something called a bird's beak pouch will lead to a stricture and a partial obstruction. And also the devascularized anastomosis, the gastrojejunostomy. And there are a few more. So these are technical issues which I hope we'll discuss in a little bit more detail. And if I have your permission, I'll show a few slides.
Sir,
Yes, sir.
I would love to continue, but our anesthetists have done their job pretty swiftly, actually, and the patient is actually ready. I'd like
Good.
to show the operating theater right now. As you can see, we're just almost ready, and hopefully, I'd like to go over the patient profile with all our attendees now, sir, if that's okay with you.
Of course.
Okay. Okay, sir. ठीक है. Just gonna share my screen here, and kindly do tell me if everybody can see it.
Yes, we can.
Good.
Okay. Sirs, today our patient, who is not named here, she is aged 23 years. She is a resident of Peshawar here in Pakistan. Her weight is 87 kgs as of this moment. She is of 5 foot 1 inch, and her BMI currently is 37 kg per meter square. She has a total body fat of 54.3%, and comorbidities this patient has developed from a very young age, type 1 diabetes mellitus, and currently due to her obesity she is having a type 2 over type 1 presentation as well. So she presented at 2 years of age with symptoms of hypo and hyperglycemia. Currently in our OPD, she came with an increase in weight from 67 kg to 87 kg in the last 2 years. Her HbA1c also showed this growth. She went from HbA1c from 6.5 to 9.5 over the last 3 years. She has polycystic ovarian syndrome as well. She does not have any obstructive sleep apnea or any osteoarthritis or any hypertension. She's currently on Actorapid and Lantus insulin regime, as you can see. Now, the past surgical history, as I've explained before, that she was diagnosed with type 1 diabetes mellitus 22 years ago. She's had multiple hospital visits since that time, since she was 2 years of age. She initially had urinary symptoms of frothing and burning, and after a pediatrician then started to, after thorough testing, was put on insulin as well. She's never been operated before, but her father here was operated for morbid obesity and type 2 diabetes with hypertension symptoms 4 years ago by Dr. Rutledge himself. So now Dr. Aatif would like to explain the patient positioning here, and hopefully you can get a better idea.
Assalamu alaikum, everyone. Assalamu alaikum, everyone. There's a lot of echo here. Nadeem? Mic then, please. मुझे माइक तो लगा ही नहीं, तो मैंने दूसरा बोला इसको मैं म्यूट कर देगा। Hello, are you getting my voice?
Yes, Dr. Aatif, this is better. This is perfect.
Okay, yeah, thank you. Assalamu alaikum and good morning and good afternoon and evening to everyone, because we are transmitting this master class globally. So as accordingly, greetings as per the time of the day. Before I need to tell you something about the patient positioning and everything, I just need to tell you about why this master class, this idea came to me, and it's just because of we are suffering with the COVID pandemic for the last almost 2 years. And now there's a variant Omicron, which is presumably be more threatening than the previous variants. So we are forced here to do something virtual, and we can't have in-person master classes or workshops or conferences. But wherever there are some threats and there are some restraints, there is a great opportunity as well. And I had this idea that why not use a virtual platform where a mentor can guide the operative steps for a mentee and tell him or her how to proceed, where to start the section. So this idea came to me, and this was the basic idea behind this masterclass. I discussed it with Dr. Rutledge, and we are very thankful to Rutledge to coming to Pakistan in 2018 and introducing or bringing mini gastric bypass to Pakistan, because before that, most of the 99% of the cases which were being done in Pakistan were just sleeve gastrectomies. But nowadays we are seeing more and more surgeons now incorporating mini gastric bypass into their bariatric practice, which is a very good sign. So what I need to do was that the basic purpose of this master class is that when I and my operative team will be scrubbed, so Dr. Rutledge will be monitoring us through Zoom from California, USA, right across the globe, and he will see how I'm operating, and he will give you tips that how I should be placing my ports, how I should be using the stapling cartridges, where should I start the section, where should I end it, so that this becomes a learning repository for everyone who wants to do a mini gastric bypass, the original technique, the way the founder, Dr. Rutledge, founded it. So let's start discussing the patient position. I'm going to now enlarge my screen. Here on the left side of the screen, you can see that patient is a previous patient which has been already on the table. So in mini gastric bypass, the position which Dr. Rutledge advocates is we don't stand between the legs of the patient. The patient is supine. We have an extreme anti-Tendelberg patient position. And if you can see that the left side of the patient is also up. So you can, and the patient has the pneumatic compression stocking. You can see those white stocking across her legs. And then this patient is secured on 3 points. You can see 3 belts which are strapping the patient to the lower part of the table so that patient has a physical stability and doesn't fall off during this extreme positioning of the patient. So this positioning I have found out to be very good, because I was used to work between the legs, and I used to have real difficulty when the patient had BMI more than 50, 60 or 70. And there were a lot of problems when I was doing sleeve gastrectomies or Roux-en-Y to do surgeries on these. But I didn't find those problems when I used this position where the surgeon stands on the right side and the camera person also stands along with him, and the surgical associate or assistant is opposite to the surgeon on the left side. So if I continue with this slide, you can here again see that how you can see the patient has been positioned, and you can see a circle drawn on the abdomen of the patient. This is where all our ports will be, and this is our working area. Whatever we are going to do, we are going to do in this area. So this is nicely and easily accessible. Now, just to give you a little bit of port positioning, how a port is being positioned, we will talk about detail that as well when I will be getting scrubbed and we will starting the procedure. But there are usually 4 12 mm ports and 1 5 mm ports in the classic mini gastric bypass Rutledge original technique. More obese the patient, higher should be the ports. If the patient is low BMI like we have today, which is 37 BMI, so we will be placing the ports a little bit more down, and Dr. Rutledge will be guiding me how to place those ports. So if you see, this is another picture of a port, and this is a very super obese person. So you can see that way down is the umbilicus in the picture. So from now here on, Dr. Najib, I'm unsharing my screen. You can now introduce the staff and the bariatric surgeons team and our OR staff and the anesthesia team. Without them, this whole exercise would not have been possible. And I'm thankful to my current administration, Dean FMTI PIMS, for encouraging us and supporting us with these activities, and also President PSMBS, Professor Mumtaz Meher, who is always a strong support for me and always backs me up in my whatever endeavors I have. And equally thankful to Professor Ghulam Siddiq, who has found out time from his busy schedule and to be here in this master class, and everyone from the who are going to attend this, and especially the faculty, starting from Professor Hassam Al-Fawal. He will join us shortly. Professor Kamal Mahawar, Professor Safan Taba, Professor Mario Mozella, Professor Asim Shabir for Singapore, Tahir Yunus for Lahore, Imran Abbas from UAE, and there are a few more which I'm just Salim Jalil Elan from Mexico, and Keaton, very good friend of mine in London, and Dr. K.S. Kular, who I think was the first disciple of Dr. Rutledge, and from Dr. Kular, the journey started of mini gastric bypass, and I have joined very recently, 2018, this journey of Dr. Rutledge with the mini gastric bypass. So over to you, Najib. So it's time for me to get scrubbed now.
Thank you so much, Dr. Aatif. And again, thank you all our panelists. Thank you to all our attendees. Just a word to the attendees. If you want to get a question answered, or if you want Dr. Rutledge or any of our panelists to elaborate something, you can kindly write it in the chat, or there's a question and answer there. You can post your question there. I'll just go share my screen again to introduce the team. Dr. Rutledge, there's a question from Dr. Hector Guzman, if you would like to elaborate on it.
Yes, could you tell me the question? I couldn't quite read it to understand it. Could you help me?
Okay, yes. The confirmation of gastrojejuno anastomosis is determinant to error. Like a reflux, if you do anterior or posterior GYA. I think that's they're saying gastrojejuno anastomosis is determinant to error, like a reflux if you do anterior or posterior gastrojejunostomy.
Well, I'm not certain exactly the question, but maybe I could try and answer it. That if he is saying that the technical performance of the gastrojejunostomy is critical for avoiding reflux, then I would agree. And so if we just imagine that the history of bariatric surgery includes a lot of surgical attempts to make obstruction. In other words, what they do, oh, we're getting some introductions.
Oh, no, please continue.
Okay, all right. So you'll have to guide me when to talk and when not to talk, because otherwise I'll talk for the whole hour. So if you can imagine the lap band, if you can imagine the vertical banded gastroplasty, and even the sleeve, the surgical technique for causing weight loss is really very simple and straightforward. It's basically causing a partial obstruction. The idea theoretically is just as simple as you could imagine, that if you have a highway which has too much traffic, all you have to do is put up a partial roadblock, and that will lead to progressive obstruction and a decrease in traffic on that road. And so with that simple approach, that's basically what we see for the vertical banded gastroplasty, the lap band, and largely I would say for the sleeve as well, because the pylorus acts much as a lap band. The MGB is not designed to use that technique, and when surgeons who migrate from the Roux-en-Y gastric bypass, the sleeve, or other techniques, what we have often seen is they will have high incidence of partial obstruction. And with partial obstruction, as we know in the sleeve patients, reflux is reported quite high. Those of you who are experts in sleeves here today could report maybe the numbers of sleeve patients suffering from reflux, because again, it's a partially obstructive procedure. Surprisingly, many MGB surgeons...
please don't mind, I'm going to stop you there. I just want to introduce our team, and then we're just getting ready in the OR. I think we'll have a lot of time for continuous elaboration.
Sure.
So today we're going to start. As you all know, our bariatric operative team. This is Dr. Aatif. Dr. Burhan is our assistant surgeon here today. Both trained bariatric surgeons, and Dr. Adnan is a colleague of mine. He is our camera operator. Our specially assigned bariatric anesthesia team, and we're going to have a presentation on what we mean by bariatric anesthesia and what total intravascular anesthesia is and recommended for bariatric patients. Professor Rana Imran is heading this team, and we have Dr. Musa and Dr. Kiran as our anesthetists today. As you all know, I am Dr. Najib, and with me I have Dr. Samia. This is our scrub staff, Mr. Hassan. And it's a point to be made here that no great surgery can be performed without great assistance. And our operating technicians are truly trained and seasoned. We have Mr. Zulfikar, Mr. Mehtab, and Mr. Jamil helping us in the OR today. So with all this done, I would like to now show you what Dr. Aatif's position is during this surgery. And as you can see that we have the patient currently lying supine, and I'll show you the camera angles as well. And for all our attendees, if you want me to switch camera angles, or if you want me to change any sort of camera view, kindly just write it in the chat or highlight with your hand raising. So as you can see, this is the laparoscopic view. This is the OR view. And we're just getting ready to insert the ports. And